I'll be just extending. Yours was primarily on craniopharyngioma, so I would just extend it to now yours was on pituitary, so I would just extend it to craniopharyngiomas. So choosing the ideal surgical corridor. So it's the kind of, I'm advocating that the gist of the topic is there are certain cases where a transcranial approach is recommended even for craniopharyngiomas. And why is that so? So 10 or 20 years back, the discussions on craniopharyngiomas in any conference used to be a debate between gross total resection versus subtotal resection and radiotherapy. Now, the last decade or so, and of course, it was on quality of life and so forth. But last decade or so, it's the debate is between an endoscopic approach versus transcranial approach, and I think to choose enough literature to show that endonasal endoscopic approach is now kind of become the standard of care for craniopharyngiomas, but not for all craniopharyngiomas. And that is what I would like to highlight, because we are in an era where the only kind of drawback or the withholding factor for endoscopic approach is now being described as the chiasm pituitary distance. If it is narrow, that is the cases where you need to have second looks. But I would say that's not the instance, because for me, craniopharyngoma is not one particular disease entity. It's a spectrum of lesions. It differs in its origin, its growing pattern, its consistency, and its blood supply. And so a one-size-fits approach does not apply. And to the earlier debate about gross total versus subtotal and radiotherapy, I think again enough of evidence to show that both of them have equal results. So that's your personal choice. But the most important thing is to minimize surgical morbidity, whether you do subtotal or gross total resection. And the two important parameters which kind of define your minimizing morbidity is choosing the right corridor and the adherence to vital structure. So that is something unfortunately not being discussed nowadays in this era of endonasal approach, because earlier the primary limiting factors that were being discussed about craniopharyngoma resection was its adherence to the stalk, to the optic chiasm, and to the pituitary gland, and to the hypothalamus. So that is some parameter which is not often discussed. So let us discuss about that first. Now, a series of classifications for pituitary for craniopharyngiomas, and it's coming again. You have more and more classifications. Some of the well-described ones are this one by Amin Kazem, and then by last late as 2020 by Santano. Here, this is 2020 publication. So you have different classifications based on infradiaphragmatic, extraarachnoid, intraarachnoid, and subarachnoid. Now, this is given way to this latest article in 2022, which highlights the adherence in three aspects: not only the anatomical structures to which it is adherent, the morphological pattern of adherence, and the strength of the adhesion. Now, these are assessed by three different, they have grades for each. So the anatomical structure to which is adherent, of course, is both in pre-op MRI as well as intra-op observation. Morphological pattern of attachment has been on pathological specimens, and the adhesion strength is again in a surgical intra-op characterization. So you have classification based on these three parameters: adhesion site, the strength, and the pattern of adhesion. So you can see the different types of patterns of adhesion itself has been described as cap-like, ring-like, so forth. The strength of adhesion, the tightness of adhesion also has different parameters. So I wouldn't go into the details of each, just to highlight that it is a process in evolution or work in progress. So the adherence of craniopharyngoma to the vital structures is of paramount importance. And that essentially is what decides your cross-total or subtotal resection, as well as your surgical corridor. So this is another interesting article published in the last year or so from Korea. They have a new classification, again, based on this adherence factors, which I described. So it's called the QST classification. Now, simple if you look at it, but I need you to follow is this green, the arachnoid line. So basically, if you see, the Q is the one which is the infracellular or the cellular type below the cella. The S is the in-between one, and the T is the one which primarily goes into the ventricle. And that is the first one is primarily extradural, the other one intra-arachnoid ones. So based on this QST classification, they had 529 cases which they analyzed, and the results the fact which I would like to highlight is that Q, the bottom one, is obviously the easiest one to take out, but type S and the T ones have more of the T ones has more of hypothalamic and raised ICP, hypothalamic involvement primarily. And this article in the Journal of Neurosurgery, again a recent one, the last 2 years, they have compared these two and they come out with this revelation that the hypothalamic status or hypothalamic outcome of hypothalamic parameters is better for the T1s if you have a transcranial approach. So I'm not advocating that all such cases need to go transcranial. I just want to impress upon the young crowd here that you do not, it is craniopharyngioma, it has to be done endonasal. That should not be the approach, and your choice of approach needs to be optimized. So this is our own study, which we published in the Journal of Neurosurgery recently, characterizing our tumor topography, but we didn't use the QST formulation, but we went on the chiasmatic and the retrochiasmatic characterization of tumors with the hypothesis that the pre-chiasmatic variants are better amenable to gross total resection, but the study revealed that both have an equal pattern of outcome. So earlier, this was a very, almost a decade-old publication. So there are a lot of contraindications for a transendonasal approach in that publication done almost sometime back, 2015, I guess, this one. From that, the indications have been, the contraindications have been kind of limited to a few of them, in fact. So this is one, the narrow chiasm, the distance with the chiasm and the stalk that kind of forbids your decompression. And in such instances, you might have to do an hemitransposition of the pituitary sometimes, which becomes a challenge. So this is the other, sorry. So these are the other instances where you need to closely relook on your decision of an transendoscopic approach, a purely intraventricular tumor. Very rare, pure intraventricular craniopharyngiomas, but this is the one instance where you need to think of keep an option of a transcranial approach. Similarly, tumors which go lateral to the ICS, which is often described. And of course, there are some patient factors, obese patients, you have them lied up postoperatively with CSF leak with a lumbar drain for 4 or 5 days, you can be sure of deep vein thrombosis and infection and other complications. Then this particular aspect, which is seldom discussed, the learning curve in transsphenoidal endoscopic surgeries, it is different for pituitaries and from craniopharyngiomas. Pituitaries are primarily extra-arachnoid, where CSF leak is not a rule in pituitary adenoma surgery. CSF leak is going to be a rule in craniopharyngoma surgeries because you're going to work intra-arachnoid. So your technique of repair has to be perfect. So how many cases do you need to do before you can kind of claim expertise in that? So there are papers describing that. Of course, the more you do, the better. But this particular case says around 20 cases of craniopharyngiomas. If you do, probably you get expertise in gross total resection and minimizing complications. But how long does it take for one person to do 20 endoscopic craniopharyngiomas in India, which is such a populous country? You see, I did some calculation based on the brain tumor registry and the works and the publications. That what the conclusion was that it will take a neurosurgeon in India a minimum of 10 years to gain expertise, and only if he works in a high volume center, because craniopharyngoma is not something which you get every day. And the prime example is my own expertise. The first I used to work in a high volume public hospital, and I had done around 142 craniopharyngiomas, majority of them transcranial. That is up to 2015. 2015, I moved to another center, and I've just done 36 in the last 7-8 years. So that is the moment you move out from a large institute, and you have hardly 5 or 6 such institutes. So it's not that you get to do craniopharyngiomas every day. And CSF leak, as Professor Asmi correctly described, it's a nightmare, and that is something which you ought to learn how to do a proper repair. And the most important take-home lesson from his talk, which I would like to reinforce, is if you have a leak, do not wait. Put this technique of putting a lumbar drain and hoping that the leak stops is not a good idea. Go in and try to repair as early as possible. And then, of course, in a low-budget, low-income country like India, this is something which is again not described, because all the people, when you go in for an endoscopic approach, you should have a liberal supply of fibrin glue, flow seals, dural substitutes, which are again all expensive. And especially as we were discussing earlier, if you have a public funded charity kind of system where you have a limited budget for each surgery, this becomes a challenge. So that is again something which needs to be kept in mind in situations where you're working with some kind of cost constraints. And of course, you need a team, an ENT team and so forth, not only during surgery, post-op follow-up. So Just to highlight two different para aspects, different from my emphasis on choosing the approach. This concept about craniopharyngioma being a pediatric disease, now a lot of more and more studies coming out about adult craniopharyngioma. This one is a meta-analysis review, which shows almost more number of adults, and this is the same observation which we made, which has been published again in pituitary. We had almost 91 cases of craniopharyngioma in the last 2 decades. And adult craniopharyngiomas, I would just like to pass and mention, are slightly easier than pediatric, because that growth aspect and the hypothalamic disturbance aspect is slightly lesser in adult. Similarly, some predictors for gross total resection. In giant craniopharyngiomas, if you're approaching an endoscopic approach, the negative parameters are, of course, this is nothing new, but I just wanted to highlight that, because even you should aim, because I am a kind of a proponent advocate for gross total resection wherever possible. So to conclude, surgical approach needs to be customized. Do not jump into the conclusion based on the radiological diagnosis of a craniopharyngoma, but you need to assess, as I said, the site of attachment, the extent, the pattern of attachment, and maybe the extent or strength of attachment, adhesion, all these parameters to be decided. And in instances, swallow your ego, and often can opt for a hybrid approach also, or a 2-stage approach also, rather than clinging on to a dogmatic approach that it is going to be endoscopic approach, because that is the current fashion. Thank you.